I'm honored to be invited here today to discuss how mental health interfaces with poverty. One cannot fully address issues of poverty or crime without understanding mental illness. We are in a mental health crisis. What I hope to illustrate for you tonight is that community mindset and coordination among social sectors of care are necessary and powerful components towards solving the discrimination against mental illness and those living in poverty. I'm going to share some content that may be triggering or emotional for some of you. Some of what I am sharing tonight is deeply emotional for me. So let's normalize that feeling uncomfortable when discussing mental illness is okay and even healthy. Tonight I'm going to cover some myths about mental illness, some shortcomings of our healthcare system. We're going to talk about solutions and cover some real-world success stories. As we sit here together today, we have more medicines, more research, more therapy, more providers, and more people engaging in treatment than ever before. And yet more people are dying of or disabled by mental illness than ever before. In 2013, mental disorders topped the list of the most expensive medical conditions, and more than 2 million Canadians have a mental illness disability. Of those 2 million, 8.3% are living in BC, the highest percentage of any province. When I meet people in my office, I often endear them as my darling or my love. For today's presentation, I may occasionally reference people living with mental illness as patients, and I do this deliberately. I want the MSP and private health insurances to recognize mental illness with the same coverage that they give to people living with cancer or diabetes. And I want the medical science field to use the same standards of care for treating mental illness as they give to people living with heart disease or Alzheimer's. However, as we move forward in this presentation and the conversations that follow, it is critical that we remember labels such as client, patient, illness, disorder, disability, or even diagnoses such as schizophrenia are socially agreed upon terms that describe a set of symptoms. They never describe an individual. So as we embark upon these conversations, we must be careful with the language that we use and not refer to a person living with schizophrenia as a schizophrenic. They are a person who's living with schizophrenia. Or someone who is living with an addiction as an addict. They are a person who's living with an addiction. And the minute you change that, you lose your human connection to them. If you break your leg on the street, within minutes, a response of concerned citizens and first responders will show up to help you. They'll help transport you to the hospital, where your injury will be examined and treated, and you'll be sent home with the necessary medications and a follow-up plan for care. If mental illness breaks your mind and you're living on the streets or behaving outside of our preconceived social conventions, the response is far less compassionate, competent, or even organized. Homelessness, incarceration, chronic medical problems, and early death are often the consequences of mental illness left untreated. Prior to the deinstitutionalization of psychiatric hospitals in North America in the 1970s, homelessness was not a large social problem in Canada. It was believed at the time that these patients would be better cared for at home or in their communities than subject to the horrific conditions of many of the hospitals at the time. But almost 50 years later, we can see that the majority of those patients found themselves either homeless or in the criminal justice system. Today, we know that on any given night, a young person with psychosis who needs desperately to be in a healthcare facility has a 50% chance of being incarcerated, a 25% chance of being homeless, and a 25% chance of being involuntarily hospitalized. 80% of people who are homeless have a serious mental illness, and 55% of the homeless population lives with alcohol dependence. Additionally, 3 out of 4 people in British Columbia prisons have a mental health disorder. I'm going to add a treatable mental health disorder. We have been discriminating against people with mental illness for centuries. When we aren't on the same page and coordinated, we often assume someone else is better equipped to respond to the mental health crisis. But leaving the mental health crisis up to the medical and mental health care providers to fix is no different than leaving climate crisis up to the biologists who study it. Let's address some of the common misconceptions I often hear in my office. Myth number 1, mental illness is the new fad. Do you guys remember those hairstyles? I do. I think I had a few of them. I hear this a lot from parents in my office, but it isn't just parents. You may be surprised to know that the American Psychological Association has also faltered under this stigma. When publishing the DSM-5, which is the manual used by psychiatry for diagnosis, they included diagnostic criteria for ADHD that is not based in science. I struggle to imagine medical science ever caving due to stigma at the expense of evidence diagnostics. Mental health stigma is pregnant with fear and avoidance that is the consequence of a lack of evidence-based, coordinated care and legislative funding. Stigma is oftentimes described by those living with mental illness as worse than the mental illness itself. As this suicide survivor shared, I had to decide, do I want to kill myself or do I want to see a psychiatrist? I hated myself enough to want to die, but not so much that I would become a mental health patient. We do not need a magic bullet here. We already know how to effectively liberate people living with mental illness from the social isolation, discrimination, and human rights violation that is the consequence of stigma. We need advocacy, collaborative, community-based care, social contact, networking, and psychoeducation. 4 goals for stigma reduction include eliminating workplace discrimination against people with mental illness, the development of governmental policies to end stigma, developing curriculum for healthcare workers and educators that is led by people with mental illness, the removal of stigmatizing content from the media, excluding people who live with mental illness from the development of our platforms is silencing the most experienced voice in the room. Dr. Insel, the former director of the National Institute of Mental Health, writes in his book, Healing, "To me, the word stigma invokes victimization and unfortunately inaction. I prefer the term discrimination, which heralds a call for social justice. Stigma by itself will not launch a civil rights movement to overcome systemic exclusion from care." Myth number 2, medications can fix it. 80% of psychiatric medications are not prescribed by psychiatrists. Because there are too few psychiatrists, physicians are often left holding the liability without the confidence of specialization to support their prescribing decisions. Further, due to stigma and side effects, and I'll add cost barriers, adherence to psychiatric medications is below 50%, the worst of all prescribed medications. While many psychiatric medications are very effective, they're not meant to be a standalone treatment for mental illness. Prozac will blunt the system, but it will not integrate it. Medication will suppress the effects, but it will not train the brain to function optimally. If we compare the treatment efficacy of Prozac for 8 weeks treatment for PTSD, you see it's only 2% better than a placebo. And, but an evidence-based trauma treatment, such as EMDR, is getting 59% after 8 weeks. I once was in a course with Bessel van der Kolk. I don't know if any of you know him. He's a world-leading authority on trauma, and he said, if you can't get a 44% reduction in PTSD in 8 weeks, you're worse than a placebo. That was really a lot of pressure. Myth number 3. There's always a hospital that can help. No, there is not. Full stop. This is perhaps the most heart-wrenching conversation I have with parents. 75% of people with mental illness report the onset of symptoms before the age of 25. That is why I mentioned earlier that we need curriculum for educators. And yet there's virtually no mental health care system for children. When there's a war coming, who do you put on the train to get out of town first? Kids, right? Yeah. Last winter, I sent a family to the emergency room with a young girl who was suicidal and experiencing her first episode of acute psychosis. At the time she was admitted to the emergency department, there were almost 6,000 youth waiting on 24 beds. The attending physician was given the same automated response from every psychiatric hospital he called. If the patient is not actively trying to kill herself in your emergency room, or she is not in a drug-induced coma, we do not have room for her. She does not meet criteria. And if she does meet one of those criteria, she will go on a wait list. The Canadian Mental Health Association reports an estimated 84,000 children and youth in BC have a diagnosed mental illness, yet less than 1/3 of those children who are seeking help are receiving mental health services. That means that as many as 58,000 children in BC are not receiving the treatment that they need. Further, I'm going to repeat that BC has 24 publicly funded beds for children. When it comes to adults living with mental illness, it doesn't get much better. Among developed countries, there's an average of 71 psychiatric beds per 100,000 people. In 35 of the most advanced countries that you see here on this list, Canada comes in 29th, offering only 30 beds per 100,000 people. It's an example of being on the top of the graph is not a good thing. Additionally, occupancy rates for a psychiatric unit should never exceed 85% for optimal functioning of the unit, and yet psychiatry hospitals in BC are often running overcapacity protocols. For those who are able to find a bed, the pressure on the system is so great that they often discharge patients prematurely with no follow-up care or coordinated plan for community-based services. If a doctor discharged someone racing for their life against cancer from the hospital prematurely and with no financial access to the medications necessary to save their life, and no coordinated care plan or communication among providers, we would call that malpractice. Myth number 4. We believe that people will seek help on their own when it gets bad enough. This is not the reality we see. The more severe the mental illness, the less likely the individual will seek care. Some people with serious mental illness don't recognize they have an illness, and so they reject care. Hopelessness that accompanies depression prevents people from reaching out. Distrust of others is a common symptom of post-traumatic stress disorder. And people with anxiety know all too well that anxiety is avoidance best friend. Now that we've looked at some of the misconceptions of the general public, let's look at our current mental health care system, and then I promise I will be positive at some point in this talk today. Our current mental health care system is failing in 3 areas, more than 3 areas, but this is what I have time to cover today. Training, accountability and regulation, and fragmented care. Number 1, training. There's a gross lack of quality control among mental health providers. Evidence-based treatments exist, but too few clinicians are actually trained in them. Over 60% of professional schools of psychology and masters of social work programs do not include any supervised training and any scientifically based therapy that works. Therapy is hard. It requires learning, which requires motivation and practice. Getting people to therapy is hard, either because they don't believe they need help, they've succumbed to the stigma of mental health, or they can't afford it, or they're on a wait list. What a disservice it is if they finally get there and the clinician is poorly trained in the modalities that are proven to help them. Further, providers are working beyond their scope of training, offering to treat conditions such as post-traumatic stress with little to no evidence-based modalities at the risk of re-traumatizing their clients. When we don't measure outcomes, confidence outpaces competency and credibility. If your appendix was rupturing, wouldn't you expect the person treating you to have had appropriate surgical training? This leads to accountability and regulation. If you look at almost any physiological illness, you'll find that there's some measure for quality of care. We don't see this with mental illness. Imagine treating diabetes without measuring glucose levels. Too few clinicians have treatment plans that track or measure progress, and no one is holding them accountable to do so. In British Columbia, counseling is not regulated, and as such, we are not designated as healthcare professionals. This is not true for psychologists or social workers, by the way. Anyone can hang a sign on their door and call themselves a counselor. The lack of regulation is putting all counselors in the same uniform and making it extremely difficult for the consumer to know exactly who the experts are. These are all designations of mental health counselors in British Columbia. Can you tell which of these has 7 years of training, 4 years of training, or 7 months of training? Do you think that the people living with serious mental illness or their distraught families have the capacity to understand the difference? Lack of regulation leads to the absence of consistent quality control. This is not in the best interest of the public, especially vulnerable populations who live with serious mental illness and are often incapable of organizing the collected action to work in their own best interests. Finally, the care system is fragmented. Service providers are not working with other professionals in an efficient way. People are used to working in closed systems, and they're focused on short-term relief rather than recovery. As this came up throughout the past couple of days in different areas, I noticed as a key thing to highlight, long-term recovery, not just short-term relief. Yes, thank you. Someone who has a mental illness that is impairing them with auditory hallucinations doesn't just want reduced auditory hallucinations, they want a quality life. If we stop at, just reducing their symptoms, we're missing the boat. When a person presents to an emergency room with symptoms of mental illness, they're too often quickly discharged back into the community without a coordinated follow-up plan. The risk for patients hospitalized for suicide attempt or psychosis goes up when you discharge them for 7 days, okay? Dr. Insel says this is a literal valley of death that you're discharging these patients into, and yet most of them receive no follow-up care with a mental health care provider. Doctors are struggling. Mental health care providers are struggling. Care needs to be coordinated, and it needs to include family, peer supports, caseworkers, and mental health care providers at a minimum. No one who is in the hospital for suicide attempt, suicide ideation, or psychosis should ever be discharged without a community-based safety plan, crisis line phone numbers, access to food, medications, housing, transportation, and a follow-up with a mental health care provider. Likewise, mental health care professionals too often don't have a collaborative relationship with their clients' physicians to ensure a full circle of care. Treatments for mental illness are rarely combined, coordinated, or optimized on patient need. The more coordinated the treatment team, the better the outcomes are for the patient. Mental illness is the largest inequality and crisis in healthcare. The crisis will not be solved by one sector of care. It will take a village, a tribe, a community, and a country. So that's the end of that part. Sorry, guys. Everybody okay? Are you guys ready to talk about solutions? Okay. Solutions. We want to start with a trauma-informed system. And we need to recognize that this is a complex process, not just a catchphrase for websites. Engaging in the principles of a trauma-informed care is critical to establishing trust and avoiding re-traumatization. This is a very brief overview of what a trauma-informed system needs. Safety. The neurobiological impacts of trauma on the brain often mean that an individual is chronically engaged in a state of fight, flight, or freeze. When an individual is chronically engaged in this kind of state, it's like having a faulty fire alarm that keeps going off, even though there's no fire. So when we're providing safety, and you're working on housing, and you're working on these beautiful peer support response programs for people in their first stage of psychosis, and all the wonderful things that we've heard today, I think we have to remember that the traumatized brain will always go back to what is familiar, not what is safe. Okay, so if they're not engaging, if you're struggling with engagement, that might be a symptom of trauma, right? We just have to be a little bit more creative about how we engage them. Transparency and trustworthiness. Remember that the mistrust of others is a common symptom of post-traumatic stress. Your policies need to have some level of transparency, and they need to be honest. Someone mentioned earlier fatigue, interview fatigue, and that one was really important to me because we ask them to give us feedback, but we don't want to always tell them what's been done with that feedback, right? Feedback and collaboration. What is your process for gathering feedback and measuring it? A trauma-informed organization is going to get feedback from and collaborate with the population that they're serving, as well as other sectors who are making attempts to service the same population. Empowerment and choice. The ability to use one's voice is often disrupted by traumatic events. Including them on your team helps them restore their voice. A brief comedy here. Fun fact, trauma dysregulates the areas of the brain responsible for verbal expression, but it notoriously leaves one area of the brain online called Wernicke's area, and this is the area of the brain that allows us to swear. Moving on, intersectionality. Some types of trauma are disproportionately experienced by certain groups because of deeply entrenched structural inequalities. Training everyone in your organization that the effects of trauma are not equally distributed among people, as well as training them in cultural competencies, microaggressions, bias, active listening, and psychoeducation is trauma-informed. Without proper training, we cannot call ourselves trauma-informed. As you can see here, 1% of Canadians will qualify for a diagnosis of post-traumatic stress disorder. 2 to 10% of Canadian military veterans will qualify for PTSD, but 50 to 64% of Indigenous Canadians will qualify for a diagnosis of PTSD. Number 2, the earlier the intervention, the better the individual's trajectory of care. I was very happy to hear I'm sorry, I have forgotten your name. Harsh. Speak about this earlier, specifically in psychosis. Psychosis happens in 5 stages. The prodromal stage is the early stages, the first 2 stages. The earlier you can intervene, the better their trajectory, okay? Which means the better all your systems are gonna work. So remember that the majority of mental illness symptoms emerge prior to the age of 25. Early intervention programs should resource parents and support children all the way through development, all the way through. The importance of early intervention cannot be overstated. The economic impact of child maltreatment is estimated at $124.6 billion. Comparatively, the total cost of the top 5 pediatric health problems equals 100.3 billion. Just a small reduction in childhood maltreatment could save billions. That's good financial incentive to invest our resources into parents, children, and families. Number 3, we need to develop a community-based human rights agenda. So let's consider the following. People living with mental illness are citizens who deserve dignity and respect. For those living with mental illness, this feels like, I have choices and I can do this. People living with mental illness have the right to be included in the community. For those living with mental illness, this feels like, I am protected and I can do this. For people living with mental illness, people living with mental illness deserve opportunities to work and play in the community. For those living with mental illness, this feels like, when I perform acts that are useful to others and they show appreciation, I experience purpose and care. All people, including those living with mental illness, function best when we preserve their freedom and play to their strengths. This creates an inclusive social fabric that welcomes all people involved to create purpose and meaning in their lives. For those living with mental illness, this feels like, I am capable and I can do this. Family involvement and interpersonal relations are valuable and necessary resources for recovery from mental illness. This is a bi-directional road of healing where who saved who disappears into a destigmatizing mindset that is caring and inviting. Improved living conditions are a necessary social determinant of health for recovery. One cannot heal when their hands are bound in surviving basic human right violations such as access to food, water, and shelter. Involuntary treatment, seclusion, and closed doors are violations of this agenda and should be the exception, not the rule. Dr. Insel shares that people living with mental illness need 3 things for recovery: people, place, and purpose. Number 4, coordinated services. Over the last 2 days, we've heard from many experts talking about solutions. As a community, it is your job to figure out how to coordinate those different sectors of care to deliver services in a more impactful way. We often see different social sectors working really well on the solutions within their area of specialization. However, those social sectors are often not working together. And as a result, we fail to deliver our services in an impactful way. This is a list of all the organizations that could potentially be working together. Remember that coordination among systems is how we make a greater impact. Number 5, family and community are not just important, they are vital variables to long-term coordinated care plan. Their voices are important and they need to have a place at the table. Mental illness is a community problem, a national and global problem. When we look at the rock star communities tackling mental illness and poverty, there's one metric that shows how successful they are: the community mindset around mental illness, and the extent to which they collectively open their doors and collaboratively work on the issues. And these ideas are not academic. They've already been put into place around the world. When I worked as a crisis counselor in Colorado, we had a sophisticated system that made great efforts towards this. When the police were called, a mental health care professional showed up with them. When someone presented to an emergency department with a mental health crisis, the physician called a counselor to come evaluate and coordinate a trauma-informed response. As a crisis counselor in that system, my job was first and foremost to evaluate the needs of the patient, coordinate with law enforcement, school administrators if I'd been called into a school, or an emergency room physician, as well as the patient's families. If I made the decision that hospitalization wasn't appropriate, psychiatric hospitalization, wasn't appropriate, then I was responsible and liable for creating a discharge safety plan that followed the patient through the upcoming weeks, ensuring that they had access to follow-up care. If I decided that they needed to go to a psychiatric hospital, I was not allowed to leave that person until I found a bed for them. I was responsible for and held accountable to ensuring that he or she had wraparound care and was handed off either to another professional, be it a hospital or a community-based team. Similar to my experience in Colorado, and actually very similar to what was just described in the previous presentation, New York State has something called coordinated specialty care programs. They're designed for youth during their very first episode of psychosis. I won't go much into it because it was very much the same as how you described yours, which is, oh, you're ahead of Rebel still. Doing great, that's awesome. Beginning in Africa and then expanding to other areas such as London, England, they have a community-based peer response program that is known as a friendship bench in front of health clinics that is staffed by grandmothers. The grandmothers were trained in basic listening skills, cognitive behavioral therapy, and a technique called behavioral activation. The grannies get a few weeks of training and support, and then they show up and support people through loneliness and depression and anxiety. They're provided with cell phones so that they can call a more experienced clinician if they need more support. But this is one of my absolute favorites. I mean, she's training, which is great. I'm huge on training if you haven't figured that out already, but also there's lived wisdom moving from someone who's been through many different life cycles, right? I really love that one. Okay, sorry, I got off track. In California, there are clubhouses that are intentional communities that provide more than just transitional housing and food for people leaving hospitalization. These are places where each day you can socialize with others, you can eat together, you can participate in organized activities and get support finding work. These houses exist in ordinary neighborhoods that are a part of the larger community. And finally, the World Health Organization names Trieste, Italy as the world standard for community psychiatry. If all you did was study Trieste model, you'd be great. Trieste model has proven its worth, safety, practicality, community acceptance, and cost effectiveness. The deinstitutionalization of psychiatric beds in Trieste worked because society opened its doors in response. They provide supportive housing, 24-hour community centers and crisis response, home care, social clubs, paid jobs and entrepreneurial companies that are created and run by the Trieste mental health care system, recreational opportunities, and social service help obtaining economic assistance. Family and friends are welcomed into an environment that is beautifully and mindfully planned. The atmosphere is very normalizing, and it promotes a sense of belonging. Anyone who is an outside visitor has a difficult time discerning who's a member of staff, who's a patient, or who is a family or visitor. But they didn't stop there. Honoring that recreation and pleasure are an important part of living, not just surviving. The center sponsors parties, trips, exercise, and art and theater workshops. You know, guys, I love trauma, is my thing, okay? It's my jam. I can geek out about it all day. And people always think that you need these really sophisticated treatments for trauma. And a lot of the times we're like, yeah, find a drumming circle, an art class, some yoga, find a knitting group, right? So there, especially if you look at the neurosequential therapeutic model of how trauma impacts the brain through development, you'll find that sometimes the last thing we're recommending is therapy, right? We're like, we gotta start somewhere entirely different right now. So these are really important things. There's just, please don't ever underestimate specifically the arts, okay? I can learn, so remember, trauma dysregulates the areas of the brain responsible for speech, okay? Verbalizing how you feel. So why not join a community choir and learn how to sing with a group of people and find your voice that way? People who have been through trauma feel God-forsaken and shame, like so much shame. It's hard to go to a yoga class because there's mirrors. Well, start yoga outside and get yourself in front of a mirror eventually, right? There's so many different ways. Sorry, I did it again. Stay on my script, okay. Community services follow the user home, to hospitals, to nursing homes, and even to the prison. Home visitors will learn about your living conditions. They'll mediate conflicts. They'll help you mediate conflicts with family or neighbors. They'll help administer medication and accompany people as needed to government agencies or the workplace. So I know what many of you may be thinking. That sounds great, Jen. It also sounds expensive. But the mental health care crisis is already shockingly expensive. Right now, Canadians are paying for mental illness in the most expensive way possible because we're waiting too long to provide access to the treatments and services we know work. We are waiting until people suffering from mental illness are in crisis. And then we're relying on an inadequately resourced, fragmented, unregulated, and untrained workforce to provide the most expensive care: hospitalization, medication, and incarceration. Each one of these people has a treatable illness. The annual economic cost of mental illness in Canada is estimated at $50 billion per year. That does not include the economic cost of substance abuse, which is another $40 billion per year. In BC alone, it is estimated that mental health problems cost our provincial economy approximately $6.6 billion a year. So I say we cannot afford to keep going like this. Some of you may also be thinking, this feels really overwhelming. It's like a ship leaking in a lot of places. So let me leave you with a story of hope. My story begins with acute lymphoblastic leukemia, a disease that affects children between the ages of 2 to 5, and among physicians is known as ALL. Some know it as all kids die, because in the 1970s, the mortality rate of ALL was 90%. And the process of dying from ALL was horrific for everyone involved. 40 years later, ALL is 90% curable. There was no magic bullet, no new medication that resulted in this change. Originally, the chemotherapy combinations resulted in remission for 80 to 90% of patients, but then they would relapse and die. What they learned was that they needed to use the treatments they already had continuously, aggressively, and for longer periods of time. Remember when I said we have treatments that work, but we're too focused on short-term symptom reduction over long-term recovery. But they didn't stop there. Every child diagnosed with ALL was enrolled into a research study that was a continued commitment to improve care for the next generation of children. Outcomes were longitudinally measured. Physicians and hospitals were held accountable and to ensuring quality care, and researchers towards the pursuit of greater knowledge. In closing, we have more medications, more treatments, more people working on the problem, more people entering into treatment, and more people suffering and dying. We don't need to wait on science to create another medicine, another treatment modality, breakthrough understandings of genetics, or more cultural awareness to start making better progress. And we won't make significant progress on poverty without also addressing the mental health crisis. The example of all reminds us that when we're better at utilizing the resources we already have, we can make great strides while waiting on those breakthrough discoveries. The valuable people in our communities living with mental illness do not need a breakthrough in medical science or psychiatry. They need social connection. They need somewhere safe and consistent to go to, and they need a sense of purpose. Tribe is the best medicine, as it is in and of itself people, place, and purpose. And to my people, my darlings, my loves, the ones who bravely face the day burdened by mental illness. I see you. I hear you. You are important. You are valuable. And you are not your mistakes. You are your potential. Healing and recovery from trauma is letting go of the stories that were never ours to hold. The judgments, the criticisms. It is a returning back to yourself with a new understanding that you were always enough. The pain you live in is treatable. The path to recovery is hard. But you already know hard. And hell was made for heroes, to walk back through the flames and find water to help your brothers and sisters who are still burning. Thank you.